Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman. If you are following my videos, and this is like I think sixth in the series of coronary artery disease, we have discussed pathogenesis of acute coronary syndrome. We have discussed anteroseptal infarction, anterolateral infarction, posterior wall infarction, inferior wall infarction, right ventricular infarction, and non-ST segment elevation infarction. And today we are going to take up another form of ischemia, which is not infarction, but it is coronary artery disease. Patient may have angina pain, patient may have resting pain, patient may have pain coming and going. And when you examine the patient, patient is normal. When you do ECG, ECG normal. It may be non-cardiac pain, but sometimes because of the risk factors, we do suspect coronary artery disease. So we have to proceed further. In this video, I'm going to show you how to diagnose a case of ischemia and those patients who do not show changes in the resting ECG, how to diagnose ischemia in those patients. Although this is the module on ECG, but since this thallium scan and angiography is also used for the purpose of diagnosis, I'm going to very briefly mention the use of thallium scan and coronary angiography in this module. So let's get started. This is a curriculum and exercise-induced ischemia is today's topic. What is exercise-induced ischemia? Now, this is the other name for chronic stable angina. Ischemic heart disease has got various types. Chronic stable angina is more or less like a mechanical narrowing of arteries. There is atherosclerotic narrowing. At resting condition, when patient is not exerting, cardiac output is low, oxygen requirement is low. So despite coronary narrowing, there may be sufficient blood supply to the heart. So there is no ischemia, no pain. Only during exertion and maybe during some emotional upset, patient has increased cardiac output, and at that time, because of the narrowed blood vessels, the demand is not met. In a normal person, increased demand is met by increased supply, but since the coronaries are narrowed, so there is no increased supply, and at that time patient develops ischemia and chest pain, and that typically forces patient to stop exercise. And whenever patient reports to the emergency or to clinic that there is no pain, and when we do ECG, that turns out to be normal. In some cases there may be persistent change, but in majority resting ECG may be normal. So this is today's module, how to handle these patients. Ischemia. Okay, so this is my institutional affiliation. So this is a patient who presented with chest pain which comes only during exertion. At rest, he does not feel any pain. So this is the ECG recorded at rest. What do you see? If you see the rhythm strip, no arrhythmia. When you see all the precordial leads in sequence 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. There are two abnormalities which attracts your attention. One is this left ventricular hypertrophy. These QRS complexes are very tall. This we are going to take up in some other module. This is because of the left ventricular hypertrophy. Maybe this patient has got hypertension. Now, left ventricular hypertrophy may cause ST depression, but patients with left ventricular hypertrophy are also prone to develop ischemia. So it could very well be ischemia. So I think based on history, you would make the diagnosis of either left ventricular hypertrophy with strain, or you would make a diagnosis of left ventricular hypertrophy with additional ischemia. To my understanding, strain is also a type of ischemia. Although patient may not have symptoms, but that is also kind of ischemia. Because whenever there is left ventricular hypertrophy, myocardium thickens, but capillaries do not proliferate. So whenever there is left ventricular hypertrophy, there is relative ischemia. And that actually is one of the risk factor for future coronary artery disease events. So if there is history, I would consider this patient having ischemic heart disease. So both ischemia and left ventricular hypertrophy. ST segment depression, TV inversion. I have already said it and I'm going to say it again. Majority of the patient with exertional chest pain, resting ECG is expected to be normal. So if the exertional chest pain is typical of ischemia, like the pain is central, patient is constricting in nature, or compression, or burning, and there is not it is not easily localized. It spreads across the chest, it radiates to the jaw, it radiates to the shoulder or the arms or the back. There is diaphoresis, and the moment patients stop exertion, the pain goes within minutes. So that is very typical of angina. I think in this patient, this ECG should be interpreted as coronary artery disease. This is another case. Imagine this patient gave you very typical angina symptom, and that comes during exertion or whenever that patient is emotionally upset. Both can cause angina. Now look at this ECG. If we analyze the rhythm strip, it is very decent, normal sinus rhythm, no ST segment changes, no TV inversion. When you examine all the leads one by one, lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. To me, I think this ECG is absolutely normal. So ECG diagnosis is different than clinical diagnosis. If you are reporting this ECG, you could say this ECG does not show any abnormality at all. But if you are treating this patient, this ECG should not rule out coronary artery disease if the symptoms are suggestive. So what do we do then? What do you think you should do? There are three possibilities. One possibility is to do exercise tolerance test. What is the philosophy of exercise tolerance test? That we put the patient on the treadmill and ask him to do calibrated exercise. And during exercise, we monitor him and we see if the patient develops any symptoms, and we also do the ECG and we also clinically monitor him. Now, we will discuss this in more detail later. The other is thallium stress test. This is also a way of uh, picking up ischemia, and you induce stress and see if there is ischemia, but we pick up ischemia based on thallium concentration, not on the basis of ECG changes. And third, and perhaps the most definitive, would be to do coronary angiography. There are two types of coronary angiography. One is CT angiography, the other is catheter angiography. Both have its own places, and very shortly discuss when to do which angiography. So in a patient who has history of chest pain and which comes on exertion and ECG is normal, you could opt one of the three. Let's take up all these three one by one. This is exercise tolerance test. This is the machine, the treadmill, the patient. We have placed electrodes on the precordium. These are the same electrodes we do in the ECG, V1 to V6. These are the actually representative of limb lead electrode. This one is right arm, this one is the left arm, this is left leg, and there was another one which is not seen, that is the right leg. And you can see the BP apparatus attached, and there's a monitor. So this doctor is actually doing the ECG, the ETT. This happens to my friend. I should have acknowledged him, and he is actually overall monitoring the process. So what is the philosophy? Patient is asked to walk on the treadmill and there are various protocols. The most popular is modified Bruce protocol. According to that protocol, first that ECG is run at a low speed and there is no inclination. After 3 minutes, then speed is increased, then further speed is increased, then we add on, we keep on increasing the inclination. So the purpose is that patient is put through more and more stress, and the during the exercise, if patient develops chest pain and at the same time you see diagnostic ECG changes. In the resting state, there were no ECG changes, but if you see ST depression of at least 1 millimeter, 1 millimeter ST depression in at least two contiguous leads, and especially if the patient also feels chest comfort at that time, I think patient will be asked to stop the exercise and the test would be reported as a positive for exercise induced ischemia. This test may be great for those who are able to do exercise. There are people who are unable to do exercise because of their joint problem, because of their lung problem, or because of the fact they have never done exercise, poor physical condition. Those who can do exercise and those patients where the history is that of exertional chest pain, this test may be great. But exercise tolerance test does not have 100% sensitivity or specificity. It has got reasonably good specificity, but it is very, very operator dependent. So I think it is not as popular as it used to be, but still can be used in those patients as I described earlier. There is other possibility that patient achieve the maximum heart rate, the maximum level of exercise which was required of him. We calculate the heart rate according to patient's age. Actually, there is a formula 220 minus patient's age. This will make sure that if you're younger, you will be required to do more exercise. If you're aged, then you will be required to do less exercise. So that means the level of exercise is adjusted according to the age. So if you achieve your full level, but still no chest pain, no ECG changes, that test will be reported as negative for exercise-induced ischemia. That patient may still have ischemia, but that is not exercise-induced ischemia. Then the third possibility, which is fairly common possibility, that is patient is unable to achieve the maximum heart rate and patient also did not develop ECG changes and no chest pain. So this test will be then reported as inconclusive. So then this patient would require some other tests. There are patients who cannot do exercise. They can be offered a pharmacological stress test. That means injection of dobutamine is given as intravenous infusion. Heart rate is increased, and you then expect the ECG changes, just like we expect in during exercise. Now, this is the example of exercise tolerances. This was the resting. Now, please bear with me. I'm going to show you something very interesting. This is the resting ECG of somebody. No ST depression at all, no TV inversion at all. In fact, this is the classical normal ECG. This could go to the textbook as an example of normal ECG. But when we do exercise, when we put him to the exercise tolerance test, look what happens. Same patient has developed marked ST segment depression. Look at this one. If you draw an isoelectric line, there is at least 2 millimeter ST depression with downslope of ST segment, followed by T wave inversion. Even more here, And this is the same as 2, limely 2, and very, very marked ST depression. So there is marked ST depression in all these, and so there is global ischemia in this patient. There may be critical coronary artery narrowing, although the resting ECG was normal. So this is important, and of course this patient requires monitoring. Now, if you are doing exercise tolerance test and patient develops these changes, but it does not develop chest pain, what do you think you should do? I think you should ask a patient to stop the exercise because we have already got diagnostic ECG changes. Further testing, further exercise may prove harmful. Okay, so this is classical example of a test which is positive for exercise-induced ischemia. This is another example. A resting ECG is normal. Patient has exertional chest pain. Resting ECG is normal. No problem at all. Now look what happens when patient does exercise on the treadmill. See, marked acid depression. Acid depression in 2, 3 AVR. No, so this is the 2, 3, and this is AVF. And also in precordial is V4, V5, V6, limb lead 2. So all ECG, many lead, they show marked acid depression. I can magnify it for you to better appreciate. I can magnify this part. Look at this, 4 millimeter flat acid depression. The flat acid depression, especially of this degree, is very diagnostic of ischemic heart disease. Now, then the next point is, how do we treat these patients? Patient has got chest pain and the ECG is normal, but ETT has shown definite marked acid depression. I think these patients should definitely go for an angiography, especially if these patients are younger. Now, we have covered this part, and the second way to unmask ischemia is by thallium stress test. Now, this is a patient who had chest pain, but ECG was normal, and this is the resting thallium test. Now, I'm sure if you're not familiar with these images, now let me explain. This is the left ventricle. You can see the anterior wall, apex, and posterior wall. This is another view of the left ventricle, like this one. This is another view, the donut view, right? So there are different views, and you can see normal myocardium, normally perfused myocardium here, here and here, and during the stress. And in this patient, usually the mechanism of exercise is usually ergometer. Ergometer is a type of cycle. Patient is asked to do exercise on the ergometer, and at the peak of exercise, to 6 or 7 minutes, patient is injected thallium. Thallium is a radioactive substance. It will go to all perfused part of the myocardium because myocytes have some affinity for the thallium. So all parts of myocardium will be outlined during the stress. Now, if you then repeat the test after some time, after maybe a few minutes, 10, 15, 30 minutes, and then the image is the same because there was no defect here, so this was expected to be the same. But if patient has ischemic heart disease, now then see what happens. This is no stress-induced ischemia. Now this is another case. Patient had ischemia, and when patient was injected thallium at peak exercise, there are certain parts of the myocardium which do not show radioactivity. Now this apex does not show much of radioactivity. This part, septum and the apex, this part, sorry, it's I think whichever wall, and this part is not showing radioactivity. In this donut, this whole part, almost half of the donut, is not showing radioactivity. So this part is ischemic during exercise. We have picked up ischemia, but this time with the help of thallium scan, not with the help of exercise, with the ETT. Now, if you allow this patient some rest, you see after some rest, there was enough time for the thallium to be redistributed. Even those areas of the myocardium which had some coronary narrowing, because additional time was given, the thallium scan, the thallium was redistributed, then that defect disappeared. See, this defect has disappeared here. This defect has disappeared here. And this apical defect has disappeared here. So this would be reported as reversible stress-induced ischemia. This is important, right? So this is equivalent to ECG, a normal ECG at rest, and ST depression during exercise. Normal scan, when patient does exercise, these are the defects, but after some time the defect disappears. This is reversible stress-induced ischemia. Suppose there were these defects, they did not disappear after rest, that would be a permanent, that would be a sign of permanent infarction. Now is the third coronary angiography. This is actually the abbreviation of CT angiography, and CT angiography is a relatively new test and it has become very popular because patients like it, but in some cases it may be useful. In some others you have to go for proper catheter angiography. In one slide I will give you the comparison to let you understand which one is the best one in the given circumstances. Now this is the geography. Now you can see in this case, this part, left anterior descending artery, this part is not showing contrast. What is the angiography? We pass a catheter all the way from the radial artery or brachial artery or femoral artery, go all the way to the aorta, and then we find the coronary arteries and then inject contrast and take these images. Of course, you need a lot of experience. Only an expert cardiologist can do this. As physician, we need to know what is this technique. So this is the defect. In this case, this is the another one. So these are actually two different types. This is shown black, this is shown white, but these are actually the same abnormality, left anterior descending artery. So 90% stenosis. You can see almost only the 10% lumen is there. The rest of it is all occluded. This is a definitive way of diagnosing coronary angiography. So that this vessel is okay, this vessel is okay, and this can be treated with angioplasty or bypass. Of course, this is a very good case for angioplasty, but in some cases, an option may be bypass, coronary artery bypass grafting. That is beyond the scope of this module. Now, this is the comparison, which type of angiography you should go for. What is CT angiography? Because of the availability of high resolution multi-detector CTs, it is possible to take the images of moving structure, the arteries, the coronary arteries. A contrast is injected into the peripheral vein, not into the artery. Just like we give intravenous injection, contrast is injected into the peripheral vein and then images of the coronary artery is taken. The advantage of CT angiography is that it is non-invasive or at least minimally invasive, although contrast can give you some issues. But generally very safe. Patient can go to the facility, have the angiography and can come back after a few hours, no problem at all. But since catheter is not passed into the aorta, so there is no possibility of going ahead with angioplasty. So that is the advantage. That is a limitation. So what is the exact place of CT angiography when suspicion of coronary artery disease is low? Based on history and ECG, if the suspicion of coronary artery disease is low, but you cannot rule out coronary artery disease definitively, and it is important to rule out coronary artery disease, then you could do CT angiography. If CT angiography is normal, then coronary artery disease is ruled out. But if CT angiography shows significant abnormality, most probably you will have to go ahead with the catheter or the proper angiography also. So this we have to explain to the patient. But if the baseline suspicion of coronary artery disease was high, then we already knew that this patient would need angioplasty. So I think we should not waste money and time for going for CT angiography. We should straight go for catheter angiography. So this is your clinical judgment. If suspicion of actual coronary artery disease is high, go for catheter angiography. If the suspicion is low, you can go for CT angiography. But patient must know that if you go for CT angiography and if it is abnormal, most probably patient will also have to then undergo catheter angiography. So this was it. Today's module, I covered a patient with chest pain who had normal ECG, and we discussed how to further proceed, and we discussed three modalities: exercise tolerance test and thallium stress test and coronary angiography. I hope this module was useful and you learned new things. This is Professor Aziz-ur-Rehman from channel Medurstand, where you have videos about all important topics in internal medicine. I welcome you to join my channel and really look forward to see you in my next video. Thank you very much.